Hello, good evening, my friend and colleagues from Asian Oceania region, and also good morning, my friends from the North America. My name is Nuchirin Tanya Supakol, one of the AsiaSafe from Thailand. So I would like to welcome you all to our webinar series on the enhancing optimization strategy in radiological practice. And today we are on the fifth webinar that we have for this series. That we are going to talk about the mammography, how can we do things better for the dose optimization and get the correct diagnosis. Before we go that far, first of all, I would like to introduce Dr. Jamari Chiapechara-Sopon, who is the AOSR president, to give us a welcome speech.
Thank you, Dr. Supakun. Good morning, good afternoon, and good evening to all our participants joining us from across the globe. On behalf of the Asian Oceanian Society of Radiology and AsiaSafe, I'm delighted to welcome you to the fifth sessions of our 2025 webinar series, Optimizing Mammography, Image Quality and Dose. Today's sessions brings together leading experts and passionate professionals committed to enhancing radiological practices. Whether you are a radiologist, medical physicist, technologist, or educator, your presence here reflects a shared dedication to improving patient safety and imaging quality. We are honored to have Professor Samuel Brady from Cincinnati Children's Hospital, USA, and Dr. Yuen Teo from KK Women's and Children's Hospital Singapore with us. I encourage you to engage actively, ask questions, and take away practical strategies you can apply to your own settings. Thank you. Back to Dr. Supakun.
Thank you so much, Dr. Jamari, for the welcoming speech and for staying with us on every webinar series and reiterate how important it is for our community. And today we also have a Professor Ng, who is an AsiaSafe chair, to join us today. And he would like to give us a welcoming speech too. Welcome, Dr. Ng.
Thank you, Dr. Supako. Hi, everyone. I'm the chair of AsiaSafe. Why is the echo? Can you hear the echo?
We can hear echo. Can you mute one of your screen?
I have
Wait for a while.
still the okay.
Yes. Okay. You can go ahead now, Dr. Ng.
No, I think a bit. Just mute. Oh, sorry about that. Yeah, welcome as the chair of the AsiaSafe. I'm Professor Ng is based at the University of Malaya Medical Center, Department of Biomedical Imaging. I'm happy that this series is probably one of the longest series on optimization in the 4 years history of AsiaSafe, and thanks to the effort of Dr. Supako, who has managed to bring different people together, radiologists, medical physicists, radiographers, and we hope that we really bring this message across to all the practitioners strongly, as optimization is a hot topic now throughout the world, in Europe, in United States, of course in Asia as well. And we also hope that this will improve our practice. Optimization will improve the image quality and, well, reduce radiation dose to the patients. And today's topic on mammography, the breast imaging, happens to be my forte. I've been doing a lot of work on that, particularly in breast density, and hope we can learn something from Dr. Brady and Dr. Teo. Thanks very much for two of you. Over to you, Dr. Supako.
Thank you so much, Dr. Ng, for the welcoming speech and joining us today. So I think first of all, let me share my screen to introduce this speaker. Yes.
You can share, ma.
Okay, got it. Okay, so for this series, this is number 5 already for the optimization strategy that we have for this year. And we have, I think like Dr. Bradley, we no need to introduce anymore because he has been here since like last year and also this year to help us on this lecture series. But I would like to reiterate how important of the medical physicist that can help us in this process. So Dr. Bradley, he is a chief clinical physicist at Cincinnati Children's Hospital and also professor at the University of Cincinnati School of Medicine. He also the fellows of the American Association of Physicists in Medicine. He has like an international experience, including as part of the IAEA expert to help establish the DRL in Thailand and also the lecturers on the IAOC Imaging Academic Outreach Center in Thailand and also the committee for the IEC for the develop technical standard for the safe performance of the CT medical equipment around the world. He also is a vice chair of the Immediately Alliance, also chair of the ABR Radiologist Examination Development for the Physics Quality on the core exam, also chair for the AAPM Annual Meeting Education Program Working Group, and also the member of the AAPM Ad Hoc Committee on the AI. And this talk cannot be complete without radiologists. So today I would like to introduce Dr. C. Yun Thieu, who is a senior consultant radiologist at the Department of Diagnostic and Interventional Imaging at KK Women's and Children's Hospital in Singapore. She's also the adjunct assistant professor from Duke NUS Graduate Medical School. She is an expert in breast imaging and women imaging with extensive experience in diagnostic breast imaging and breast intervention. She was a head of the breast imaging unit at KK University, KK Hospital from 2014 to 2015, and also head of the department from 2019 to 2021. She also was the Deputy Academic Vice Chair and Organization Transforming and Informatics Radiological Science Academic Clinical Program from 2019 to 2021, and also the member of Sync Health Academic Grants Review Committee from 2019 until now. So before we go to the talk, there is a couple things for the audience to do. So I believe that you already logged on to the VDoctor platform to watch this webinar online. A couple things that you need to do is you need to put your names to join the chat for the message. So during this talk, you can send us a questions or what you want the speaker to clarify for you. But before you can do that, you need to put your names on that chat box to join the conversation. And like in the meantime, if you have your cell phone in your hands, can you scan this QR code? Because at the end of this webinar series, we want to know how can we do better to serve the community, to make things clear for you and help improve the healthcare system in our Asian Oceania region. So if you have a chance, use your cell phone to scan this QR code, and I will add the link on the chat box on the VDoctor platform so you can do the evaluation, real-time evaluation for us on what can we do better and what the webinar series that you need for the next time. And so I'm gonna give the stage back to Dr. Bradley for his talk on the physics aspect on how to optimize the image quality and how can we do better on the mammography. So welcome, Dr. Bradley.
Thank you very much. I am sharing my screen. I am excited to be back with you. As Tanya mentioned, you're probably getting tired of seeing my face, but I am always excited to talk about the physics of various different imaging modalities. And today we're going to talk mammography. And this is an interesting topic. Historically, of course, breast cancer, the incidence of breast cancer has not been as strong in the eastern side of Asian side compared to, say, the western side of the world. But in the recent about 5 or 6 years, there have been several publications that have come out demonstrated an increase in overall cancer incidence, breast cancer incidence, and we are now seeing even an increase in mortality. And you can see in this publication from 2022, a breakdown based on various different Southeastern Asian countries and the rate of breast cancer. And so more important now than ever is the discussion of optimizing for mammography. So when we talk about mammography, it is typically one of three modalities that are used to screen, dental being another one, and CT for lung cancer being the third. And so when we talk about optimizing for mammography, it's actually a very complex topic because we don't just use one modality, X-ray based imaging, but we actually use all the modalities. And so today I'm going to very briefly discuss some of the topics of the various different ways we can image the breast, but I'm largely going to focus on the radiation or the X-ray based mammography system. So ultrasound has become a wonderful adjunct modality. We use we use a lot, especially here in the US. When you use traditional ultrasound, it's phenomenal at being able to differentiate between cyst or benign imaging tumors versus malignant. The traditional ultrasound transducer can provide you vascular imaging through Doppler elastography for stiffness measurements. And it is because of its footprint or the size of the transducer, it can image anywhere along the breast or in collateral areas such as in the axilla for lymph nodes. But the downside of traditional ultrasound is that it is a relatively small scanning area. And so it does require a certain level of education as to how to image to be able to find the disease. There has been recent publications over the last 4 or 5 years demonstrating a new technology, which is a large field of view area ultrasound system. To my knowledge, there's only one on the market that you can purchase. But what it demonstrates is the idea or the importance of ultrasound in trying to make it more beneficial for breast imaging in general. In this example, in this one product, here you can see that it is a full field, large area ultrasound system. The benefits for this is that it presents the breast anatomy in a surgical plane, i.e. in the coronal plane, though you can get axial imaging too. And it does, however, present the disease a slightly different than what we're used to using traditional ultrasound. For example, malignant imaging tends to be what they call a black hole. It's hypoechoic with the hyper-intense speculation and usually a hyper-intense rim around it. The whole area ultrasound system still does require some compression, but not nearly what we deal with in X-ray based imaging. The downside, of course, of this is that it does not provide any vascular or elastography type imaging. And because of the shape, it's very difficult to image into the axilla. So it is largely breast only imaging. Breast imaging itself, however, compared to the traditional full field digital mammography or X-ray based imaging, has a very high sensitivity. So ultrasound alone, 85 to 90% sensitivity for disease detection compared to X-ray based, which is about 75 to 90%. When you compare ultrasound plus X-ray based imaging, your sensitivity rates are nearly perfect across all breast types, being they fatty up to highly dense or very glandular. The detection rate for cancer increases when we use ultrasound along with X-ray based imaging. Probably the gold standard for imaging in breast is going to be MR. The tissue contrast in MR is exquisite. It gives you the ability to see very seamlessly the glandular tissue and the disease from that, being able to differentiate the disease from the actual base glandular tissue. MR, however, is difficult in the sense that it is very expensive. And typical MR acquisition times are going to be in the 30 to 40 minute range. There have been some publications recently and a lot of work towards creating a new sequence called FAST. MR FAST provides very quick, as it's named, about 8-minute sequence compared to about 30 minutes. And it provides the ability for the radiologist to differentiate disease very easily compared to traditional X-ray based mammography, comparing this patient, very dense glandular tissue, dense breast, and you can see in the MR instance on the right compared to the X-ray based, how the disease really stands out. And this is why when you look at detection rates, MR is hands down the best modality for disease detection in the breast. Sensitivities range between 90 and 100%. And you may wonder why it's higher, but the 90% reflects the fact that most of the time we use MR for very difficult cases. And so because of that, sensitivity it can suffer a little bit in the statistics. Now, there is dedicated CT for breast imaging. This is pretty rare. Most places do not have this modality, but it does provide the ability to see volumetric imaging like MR, and it's very good at differentiating the tissue, the various different tissue types, fat versus glandular versus disease. And in a study, they compared MRI versus CT and found equivalency in disease detection. Because the patient has to lay prone, they still list this as somewhat uncomfortable, not nearly as uncomfortable as breast compression that we use in X-ray based mammography. Another adjunct to this is nuclear medicine. Nuclear medicine, so mammosynthography, uses technetium sestimibbe. And this is oftentimes used for the most difficult of cases to interpret in the presence of scar tissue, implants, or severe dysplastic disease. And interestingly enough, just a couple of days ago, there was a publication, a publication is coming out, but the embargoed publication was presented, and we were able to review the results. And it demonstrated the power of mammosynthography as an adjunct to radiation-based or X-ray based mammography. So mammosynthography in and of its own has a relatively lower sensitivity and specificity for disease detection, and that's largely because it's not used as often. But when you pair it with X-ray based mammography, you can see that cancer incidence and cancer detection rates go up significantly, and it is demonstrating a very good and a secondary adjunct modality for X-ray based mammography. And then finally, PET imaging. We do not use PET imaging for breast imaging because the resolution is poor. It's about 1 centimeter, and so we're dealing with disease that's much smaller than that in the breast. So we do not use PET. Now, there are different ways to use X-ray based mammography, and we're going to get into kind of the optimization of that. But as an adjunct, as a way to use it different than the way we typically use, a new method called contrast enhanced mammography has become a lot more common, at least here in the US and Europe, in some places in Europe. And this is a traditional X-ray based imaging mammography system, but now we're introducing a typical iodinated contrast. So the process for this is fairly simple. It's not much different than what we deal with in CT, where we have to check the kidneys to make sure kidney function is okay. The injection protocol for contrast enhanced mammography is fairly simple, about 1.5 milliliters per kilogram at 3 mLs per second. Then we always do a saline flush to keep the bolus, the iodine bolus, grouped. And then you can begin imaging if you're going to do standard FFDM, so single view, CC, or MLO views. You're usually going to start with the abnormal breast or the suspected abnormal breast. If they're both suspected, then you just image left to right and move on. You can do DBT, or a digital breast tomosynthesis, with this. And the benefits from using contrast enhanced mammography are really twofold. One, it uses the exact same technology that you already have. So unlike bringing in ultrasound, MRI, CT, or nuclear medicine, this technology can be performed on the X-ray based mammography system without making any additions other than just injecting contrast. And the detection rate is getting to be nearly as good as MR based mammography. The way we acquire a contrast enhanced mammogram is that we acquire a high KV and a low KV, and we simply subtract the two. And because of the contrast attenuation differences of the iodine, any disease that takes up the iodine and absorbs it will be presented quite obviously in the subtracted image. We obviously have to take 2 images, so the dose is doubled in this procedure. And there are some common artifacts. One of them is called breast in breast. And that is due to the fact that at high and low kV, the X-ray scatter distribution is different. And so there's no real way to get rid of that. You just have to read through this artifact. So now I want to shift gears. So that was kind of what are the optional tools that we use to optimize around mammography or breast imaging in general. Now specifically, let's talk about X-ray based or traditional mammography. There are 3 things we need to optimize. The first is spatial resolution. We obviously need to be able to image very small, high contrast structures. So microcalcifications come in all shapes and sizes, but really we need to be able to image down to about 100 to 300 microns. The shape and distribution is very important to our radiologist colleagues. And this is, of course, a hallmark or marker for indication of breast cancer. And so to maximize spatial resolution, we need to have small focal spots and very low MA. Now, on the flip side of that, we need to be able to visualize low contrast structure. When you look at the glandular tissue versus fat, it's always at any kV that we use, we can pretty much always differentiate the two. And the example is on the right, a traditional CT scanner imaged at a relatively high kV. Glandular tissue and fat, no difference. I mean, no problem differentiating the two. But what happens is when you're at the higher kV, the difference between disease and glandular tissue is no different. The grayscale is the same. And so it's very difficult to differentiate the two. And that is why in mammography, X-ray based mammography, we image at very low kV so that you can see a slight separation in attenuation profiles between the disease itself and the glandular tissue. To get really low kV imaging, we have a fairly noise-free image, we have to image with higher MA. And so here is the conflict immediately. Good spatial resolution requires low MA. Good low contrast visualization requires higher MA. And then on the other side of all of this, because it's a screening modality, we are going to be imaging largely asymptomatic, normal population. Therefore, we don't want to harm the population by overexposing them. And so we have to keep the dose very low. And generally speaking, the doses are very low in everything we do. Full field digital mammography, so planar imaging, and DBT, digital breast tomosynthesis, which is the volumetric imaging, those doses per view are basically the same. So when we look at the X-ray system itself, the mammogram system itself, it's really not much different than any other X-ray system we've talked about previously, and that you've probably learned and used over the course of your career. The difference is in basically the structure. It's smaller and more compact. But one of the things I'd like to talk about is a subtle difference between the X-ray tube design and, of all things you're probably going to think about, you think I would talk about, I'm actually going to spend most of my time talking about the compression paddle, because I think these two areas are some of the best ways for us to optimize X-ray based mammography systems. So when we look inside the X-ray tube, of course, we have the cathode, right? This is where we create the electrons, we boil them off, and then we accelerate them inside the X-ray tube to create X-rays. And as I mentioned, we want to have very small focal spot sizes so we can resolve the smallest structure. But because they are MA limited, if we have too much MA, we'll burn them out, which is an example here. You can see this focal spot burned out because I got too much MA and it broke. And so to compensate, since we can't use a high MA, we just have to image longer. So in mammography, X-ray based mammography, we typically image longer. So for contact FFDM, it's usually 1 to 2 seconds. Magnification mammography, it can be upwards of 3 seconds. And so the thing we have to be careful with is motion, patient gross motion, bulk motion, which, as you can see in this top image, really degrades the quality of the image compared to the image in the bottom, which was a retake of that same patient's breast. And then on the other side, so there's the cathode, of course, and then there's the anode, which is the target. These are where the electrons interact, and this is how we create X-rays. In modern X-ray-based mammography, we almost exclusively use tungsten as a target now. And why is that? Tungsten is a higher, more efficient material to create X-rays. It's got a higher melting point, so we don't have as many problems with heating issues, and it creates more X-rays per electron than other materials. Historically, we have used molybdenum and rhodium as targets. Those characteristics of those two targets were very important when we used film which is largely being replaced in most places. And now there may be some incidences in some hospitals that are still using old film-based mammography systems, in which case they're going to be using a moly or a rhodium target. Now, why is it that we are moving away from tungsten? In the digital world, I'll show you in a second, image quality has improved and doses have come down lower using tungsten versus molybdenum and rhodium. And then finally, using breast tomosynthesis. So instead of just doing full contact, the planar imaging, to now image a volume of the breast, we need a tungsten material so that it can absorb the heat a little better, because now we have to take multiple images over the arc of the tube. Now, when you look at image quality as a figure of merit, FOM, so now I'm looking at CNR divided by the mean glandular dose. So I'm trying to equate image quality and dose. What I'm doing is I'm comparing various different targets, molybdenum and W for tungsten, and various filters that we use in mammography. And so a typical, the two I'd like to compare for you today is this molybdenum rhodium, this open circle, and the tungsten rhodium, this closed black square. These are the two most common types of systems you can buy on the market. Now, for relatively thin compressed breasts, you can see that the tungsten rhodium and the molybdenum rhodium, those lines basically sit right on top of each other. That means for pretty much every KV we're imaging with, so low to middle KV, we are basically getting the same image quality for the same dose to the breast. But as we go to thicker compressed breasts, you can see that the tungsten rhodium, this line is higher. That means you get better image quality for lower breast dose compared to the other material types. And this is the main reason why we're moving away from molybdenum as a target and towards tungsten, because it's better for the image quality and it's better for the breast dose. So of all the other things I wanted to talk about is compression. Compression is probably one of the more difficult factors to normalize in mammography. Too little, too much really directly affects the overall image quality and the patient dose. So let's talk about the 6 reasons why breast compression is very important in X-ray based mammography. First, it reduces motion. I already told you that we want small focal spots, low MA. Therefore, we have to expose for a long time. The compression paddle actually does help hold the anatomy in place during the imaging to reduce motion. The second is what we call geometric blur. And geometric blurs is simply, what that is simply is that when you take an object, the closer that object is to the detector, so think of the structures within the breast, the closer they are compressed towards the detector, the sharper the edges of those structures are. So the glandular tissues, the ligaments, the ducts, even the cancer itself, the edges, the margins are going to be sharper, less fuzzy, less blur. Whereas the farther they are away from the detector, the blurrier they are. And so compressing or pushing the anatomy closer to the detector actually improves it reduces the blur in the image. Of course, by compressing the breast, it reduces overlapping anatomy. But reducing overlapping anatomy actually improves dynamic range. Now, what dynamic range defines is the reconstruction algorithm's ability to create an image that goes from very high white to very dark black. And so when you have a structure like an implant in here that is also very attenuating, you can see that the dynamic range of the breast tissue itself is very poor. It's largely one color. Whereas in this example, where they were able to manipulate and move the breast implant out of the field of view and acquire the image again, here you can see a lot better visualization of the breast tissue itself. So overlapping anatomy improves the ability to see subtle levels of gray in the image. Obviously, it can create a more uniform breast thickness. When our radiologists are comparing the say left or right breast, they're looking for symmetry. And if you do not compress equally well, you will get asymmetric breast images, and asymmetry can be a false positive sign for disease. Here at the bottom, you can see asymmetry due to disease. At the top, you can see asymmetry due to improper compression of the left breast in the CC view. And so consistent compression helps keep the image the same from left to right when looking for symmetry. Additionally, compression reduces the amount of scatter in the image. If we have a more compressed, thinner anatomy, we generate less X-ray scatter. Less X-ray scatter means the image is cleaner and easier to review. And finally, a compressed breast, so less thick tissue, means we do not need as much radiation to image. And so typically when we're imaging with KVs down in the 2030s, which is an effective energy of 20 keV, what we're going to see is we're going to measure a half value layer of tissue about 15 millimeters. That means every 15 millimeters of tissue, we lose a half of the X-rays. They are absorbed or scattered away. Therefore, thicker breast tissue needs more radiation to penetrate. So for example, a 4.5 centimeter compressed breast, only 1 in 8 photons will arrive at the detector. A 6 centimeter compressed breast, only 1 in 16 photons will arrive. To keep the image quality the same, we have to have higher radiation output for thicker and thicker breasts. So compression generally keeps the overall breast dose low. Compression forces are very difficult to maintain. In the literature, scientific literature, it is the #1 concern for lack of consistency, is being able to calculate the force necessary to compress the breast. Standard force calculations would say that we apply about 11 to 20 decanewtons, or in English standard, 25 to 40-ish, 45 pounds of pressure. That's the standard for imaging with force. In reality, most technologists, they adjust the compression based on their experience, the size of the breast, and the pain threshold for our patients. In the US, our recommendation is to compress until taut or tight and just less than painful, which is not very scientific. And that is why we see a lot of variability in our compression. More recently, there have been several developments to help provide more consistent compression. And this comes in the form of something called patient-assisted compression, or PAC, compared to when the technologist does all the compression themselves. So the way this works is the technologist will get the breast into position, and then they will lower the compression paddle until it's lightly compressing the breast. Then the patient has this control here, and the patient themselves will actually apply the remainder of the compression. And they have shown in publications that when the patient is in charge, they see more consistent compression, so better general and consistent image quality, less patient anxiety because they're in control. And there have been studies that have showed no difference in sensitivity and disease sensitivity and specificity detection when it's patient controlled versus technologist control. So how do another way to consider this and is the fact that when we calculate force alone, we use force to define how much compression, we get a lot of variability. And it's because it does not take into account the size of the breast. And so there's been a large discussion over the last probably 5 to 6 years, probably even more, like 10 years, where there's a push to instead of using force, to use the term pressure. Pressure is force times area. And so it takes into account the force applied to the breast and the area or size of the breast. In a recent publication in 2017 in PLOS ONE, there were a study in Asia, and there were 16,000 enrollees, and they used a paddle that actually, instead of just telling you the force, it would demonstrate the pressure. And they measured that the average pressure was about 17.8 kilopascals. And they found that the overall image quality and it was better, and patient comfort was consistent. And so by using pressure, it takes into account the size of the breast instead of just forcing the breast into compression. So this has been full contact breast imaging. So planar imaging in the CC or the MLO view. Of course, we use digital breast tomosynthesis all the time. So digital breast tomosynthesis, of course, is when we acquire multiple images across an angle or an arc over the breast, and we acquire those images all together, and we create a three-dimensional view of the breast. So it's a volume image. Digital breast tomosynthesis requires less compression. Obviously, it gives us 3D view, so it removes superimposed tissue compared to the FFDM 2D view. And even though we're taking multiple images, each image itself is low dose, and so the overall dose is fairly equivalent to FFDM. So we're not increasing the dose risk, we are just acquiring, and we're able to get a 3D view of the breast at basically the same dose. So you've all seen tomosynthesis images. We basically image the breast into 3 dimensions and cut it up like a loaf of bread, or slice it up, and then you can sort through it with your mouse, and you can go up and down or through the z-axis of the breast. And any disease that is in focus on one particular depth of the breast will become very easy to see, whereas it's more obscured at the higher and lower levels because of the overlapping anatomy. When we image it with DBT, we have several options. One is to have a large sweep, so somewhere between 25 and say 30 degrees. The larger the sweep angle, the better the resolution is in the z-axis or the slice-to-slice axis. Smaller sweeps will have less what we call parallaxing, so there's less movement of the image, of the structures inside the image from each angle. And so it therefore gives you a better ability to see smaller, more subtle structures like calcifications. Digital breast tomosynthesis, when compared to 2D FFDM, has been shown to have higher detection rates and fewer false positives than its counterpart, the FFDM. And overall sensitivity is higher. So from a purely statistical perspective, DBT has a higher detection rate than FFDM. Now, the 2D view is very important. The 2D view allows you to do breast-to-breast, side-to-side comparison, so you can do interval comparisons. It allows you to see gross anatomy, so the whole overall structure. And because of that, we will take our DBT images, the stack of slices, and use mathematics to create a synthetic two-dimensional image. These synthetic 2D images have been shown in research to be fairly similar in sensitivity and specificity in disease detection for traditional 2D FFDM. So like I said, they give you all the same features of distribution, interval changes, being able to do side-to-side comparisons. Synthetic 2D views are better at looking at microcalcifications than their original 3D DBT slices. And because we simply use mathematics to create the image from the 3D view, there is no additional radiation dose. And so you can get a stack of breast images, a 3D image, and a synthetic 2D image, and it's all the same radiation dose. So the next thing I'd like to talk a little bit about is how we calculate the dose. So in mammography, in X-ray-based mammography, there are 3 ways to estimate radiation dose. The most common is mean glandular dose, MGD, or D sub G. The problem with this is you need to understand or estimate how much glandularity is in the breast from the image. And that is not very easy to do. And because of that, a lot of these estimates using mean glandular dose tend to overestimate the actual dose to the breast. There are, so what we do is we take the air kerma, so the X-ray output, and we multiply it by this correction factor. And this correction factor is established using various different simulation softwares, Monte Carlo techniques, to estimate roughly how much glandularity would be in various different breast sizes and thicknesses. And so it's an estimate. It does not tell you the actual patient dose, but it gives you a relatively good estimate of the actual dose to the patient. And here you can see in various different vendor implementations of the mean glandular dose, you can see how the values are actually a little bit different. This dashed line that bisects the plot is what we call unity. So if you were to measure a 3 milligram mean glandular dose and actually simulate it or calculate it, if it was true, perfectly true, it would fall on this dashed line. And you can see that each vendor has its own way of calculating the mean glandular dose. Some are very accurate and very precise. Others are accurate, not as precise. And some are not very accurate, especially for larger breasts. And this has everything to do with the fact that the way they estimate glandularity in the breast is proprietary or unknown. There is another way to do this called average absorbed, or 2A, average absorbed breast dose. And this takes all the information from the DICOM information of the image, and it puts it into an equation, and it calculates what the rough estimated dose would be based on the KV, MA, filter, all of the features that we use in acquiring the image. So it's purely mathematical. And it is fairly accurate, within about 10%, generally speaking. And the nice part is this does not require estimation of breast glandularity. And then finally, we can calculate effective dose, which is an estimate of risk. In this case, we're going to take whatever breast dose tool we have, or metric, mean glandular dose, or 2ABD, and we multiply it by a tissue weighting factor, which estimates the risk of carcinogenesis when the breast is exposed. And we can calculate the effective dose, but when we calculate effective dose, this assumes both breasts are equally exposed. So if you're only exposing one breast, you have to take the results, and divide it by 2. In the US, we typically have effective doses about 0.4 millisieverts per view. And then in Europe, they're about 0.3 millisieverts per view. And then finally, I just wanted to talk a couple of minutes about where we're going with disease detection. In the US, we have been using CAD technology, which is reader-assisted software to help identify disease in the X-ray-based mammogram. And we've been using it since the 1990s. But in the 2018, our Medicaid's, so our government organization or agency that reimburses for these studies stopped doing that because false positives in CAD technology was too high. So we were seeing over $400 million of unnecessary medical cost based on unnecessary biopsies, high recall rates, etc. So we've stopped. CAD technology is still available, but you just can't be reimbursed for it. But with AI, there has become a new version of CAD AI, that's been developed using new sophisticated models. The traditional CAD technology required on a person looking at the image, extracting what they thought were the important features, and then training the model to determine disease. In the new AI deep learning models, that person's been removed, and now we use a more sophisticated AI deep learning model to detect the disease burden. With these new AI models, however, they are only as good as they are trained. And so if you use a lot of training data, especially here in the US, you're going to have a bias towards Caucasian women. And we've seen publications where you use this technology, this AI CAD, but then applied to other ethnical groups such as Asian, African American, or Hispanic. And we see in this case an overestimation of breast cancer in African Americans and actually an underestimation in female Asian Americans. In addition to this, another issue that we deal with these AI models is most of the disease burden is in older women. And so therefore, if a younger patient shows up for a mammogram, they're going to be biased to not find disease as well. And so AI models are constantly being redeveloped to be more sophisticated. And here's an example of one that's come out of Europe. Europe's a little bit more advanced than we are here in the US, where in 2019, they created an AI model that was about 80%, that had a detection rate of 0.814, which means that they basically beat out in a study of 101 radiologists, the detection software beat 62 of the radiologists, but 39 of the radiologists beat the software. They fast forwarded into 2024, and they have been working on adding more data to their study and to their training model. And now you can see in a study of 115 radiologists that it beat all but 5% of the radiologists. So the software itself has become very good at recognizing disease when there truly is disease in the image. In a study, they wanted to make sure that there weren't any false positives or there wasn't a higher recall rate. So they did a control arm where they had the radiologist read the images versus AI that would read the images. And they found, once again, that the recall rate was basically the same. So there weren't a lot of false positives. Detection rates were a little bit better in the AI arm, which makes sense, right? Because you have a radiologist and an AI reading it. And moreover, it actually reduced their overall burden. So reading times dropped by about 53%. So they saved a lot of time. One of the things they're trying to decide now is how to use AI. And one of the things they've done is they have created a certainty score. And they found that AI is really good at determining normal when the images are easy to detect. So a really good, easy, normal image, it's almost always accurate. And so if you assign a score of, say, 1 to 5 to a normal image, so a normal image, and the AI looks at it and says, this is normal, and it says, I am very certain, so it gives you a score of, say, 1 to 5, then the doctors in this study in Europe, they basically said, that's fine. A radiologist doesn't need to look at this. If it has a score of 6 to 10, which means it's a little less certain that it's going to be normal or abnormal, it's normal, then the radiologist will intervene, and then they themselves will read, and they'll make their decision. And so when you look at adding a certainty score, so not just it's good or bad or normal or abnormal, it says it's normal and I'm fairly certain or less certain. And what they found, once again, was the workload reduction was still 50%, detection rates were still really high, but the recall rate and false positives were very low. So in summary, one of the things we've seen about optimizing X-ray-based radiography, mammography, is moving towards tungsten targets, improve image quality, and reduce patient dose. We, of course, know adding DBT to FFDM imaging helps keep the dose equivalent, but it increases sensitivity for detection rates. Compression is key. It's probably the least sexy thing to talk about in the imaging chain, but keeping consistent compression helps the patients feel comfortable and come back for screening for year after year, but also it helps to make the images consistent for our radiologists to read. And AI plus mammography is the future. We need to have studies that are very specific to the populations in which they'll be used. So in Southeast Asia, if you haven't already, you need to have these AI generated models developed from your population to reduce the bias effect that you would see if you used off-the-shelf technology developed in Europe or America. So at this point, I say thank you and look forward to your questions at the end.
Thank you so much, Sam, for very informative detail on the physics aspect of the mammogram. And the next speaker is Dr. Thieu, who are going to talk about the radiologist aspect on the optimization and how can we reduce the radiation dose on the patient. And in the meantime, I think we are right on time because we just recently noticed that this month, October, is the Breast Cancer Awareness Month. So I think like our topic is right on time to make the awareness on the optimization and how to detect the breast cancer. Yep, welcome, Dr. Thieu. Yep.
Hello, thank you, Dr. Tanya, for that kind introduction, and thank you to the organizing committee for inviting me to talk about optimizing mammography. I'm happy to be sharing this topic, which is very dear to my heart. And as you rightly said today, this is the BCAM month, the Breast Cancer Awareness Month, and it is entirely appropriate. So I'm going to share more about the clinical aspects of mammography and what we can do to optimize its performance. So why optimize mammography? It is important to optimize mammography, which can include screening as well as diagnostic mammography, because the accuracy and the effectiveness of these modalities will depend very much on image quality. Women will undergo mammogram examinations repeatedly throughout their lifetimes, and the breast is a radiosensitive organ, and it is at risk of the radiation exposure of developing radiation-induced breast cancer. So that is a small risk. Therefore, as breast imagers, we need to be able to achieve the highest diagnostic accuracy with the lowest reasonable dose by employing the ALARA principle. These are some radiation dose metrics. The previous speaker had already talked about it. So briefly, the mean glandular dose, or MGD, is the quantity of radiation energy that's deposited per mass of tissue and is expressed in milligray. This is the metric that is used, I think, most widely by physicists and other healthcare professionals in measuring breast dosimetry, as well as in quality control. Another measure is the effective dose, and this takes into account the tissue weighting factor because different tissues within the body have different sensitivities to radiation. And for the breast, it is a factor of 0.12. And this is expressed in millisieverts, which we are quite familiar with. So what is the risk of radiation-induced cancer? What is the risk with exposing patients to the small amount of radiation in mammography? There is a measure known as LAR, or the lifetime attributable risk. It is a measure that is developed by the US National Academy of Sciences on biologic effects of ionizing radiation. And this provides an estimate on the probability that an individual will develop cancer due to radiation exposure over their lifetime, factoring the age, exposure, and gender. So this is a paper that is reported based on modeling, reported the incidence of breast cancer, estimates of LAR, so the lifetime risk of developing a breast cancer due to breast imaging exposure. And if you can see here at the top row, if a patient starts screening at age 25 yearly up to age 80, the incidence is about 204 per 100,000 assuming a mean glandular dose of around 3.7 milligram. If she starts later, starting from 50 and undergoes annual screening up to 80, the incidence then drops to 31 per 100,000. In this other paper, which looked at different screening regimens, so if she starts at 40 and screens annually with a total of 10 mammograms, the incidence per 100,000 is 15.9. If she starts later, so 10 years later from 50, then the incidence drops. If she does biannual screening, then this is half. It's roughly about half of the previous incidence. If there's a mix of both annual and biannual screening, for example here, if she starts annually from 40 to 49 and subsequently biannually up to 59, incidence is around 19.6. And if it's annually from 40 to 55 and biannually up to 74, the incidence is 23.3. And this is similar to if she had undergone annual screening from 40 to 59. So what does this tell us? These two studies tell us that the risk of radiation-induced cancer increases the younger the patient is when she starts screening. And if the screening is more frequent, then the risk increases. However, we have to remember that that breast screening, mammography screening for early detection of breast cancer detects a large number of cancer in its early stage and is indeed has been shown to save lives. So in these two modeling studies, the first by Yaffe et al., looking at a large number of patients, the lives saved due to earlier breast cancer detection was 497, with bearing in mind that there was radiation-induced breast cancer of around 11 deaths, and this leads to a benefit to radiation risk ratio of 45. This other study by Miglioretti et al. Estimated that there were 968 patients who were saved because of earlier breast cancer detection, balanced by 16 deaths that could have been caused by radiation. And this leads to a benefit to radiation risk ratio of 60. So fairly similar. And therefore, these two modeling studies show us that yes, mammography is associated with radiation risk, but the consideration of the large number of lives that have been saved because of early detection is something to be noted. So therefore, we balance a small radiation risk with large health benefits by early breast cancer detection. I'm going to talk a bit about screening mammography. As Dr. Brady talked about earlier, nowadays, screening mammography come in different types. There can be 2D FFDM, full field digital mammography, which is has been traditionally been done for many years. There is digital breast tomosynthesis, or a combination of the two. The frequency of screening is also different depending on region and institution. It can be annual, biannual, triannual, or a mix of these screening intervals. Mammographic workup is a form of examination that radiologists do to evaluate further an abnormality that is detected. And this can be because of a recall from screening mammogram or because we see an abnormality on diagnostic evaluation. And there are different types. A spot compression view can be performed. The dose is usually lower or similar to a standard view. Magnification views tend to have higher doses, around 1.5 to 2 times standard view, and DBT. The maximum mean glandular dose that's recommended for a mammogram is up to the maximum of 3 milligray for a 4.2 centimeter compressed breast phantom, as indicated by the NQSA and American College of Radiology. So this is a paper that looked at the radiation dose of digital breast tomosynthesis and comparing it to digital mammography. It is a randomized controlled trial. About 1,200 women in a screening trial underwent either FFDM or DBT. So there were almost 4,800 images. So for a CC FFDM view, the dose was around 1.37 milligray. For the MLO view, this was similar. So for the MLO FFDM view, this was 1.37. For the DBT, the CC view was around 1.86 milligray. Similarly, it was around 1.88 for the MLO DBT view. So you can see that the DBT views showed a modest increase in dose compared to the FFDM views. However, both doses are still way below the 3 milligray standard that have been set out. This other study looked at different combinations of DBT and FFDM. So for a standalone DBT1 view, the dose was 0.34 to 1. 2 views, 0.68 to 1.2. If it's a 1 view DBT with a 1 view FFDM in the CC plane, it is 1.03. 1 view DBT with a 2 view FFDM, CC, and MLO, this was higher, 1.03 to 1.50. The highest dose, of course, is when we perform a 2 view DBT and a 2 view FFDM, CC, and MLO, and the dose was 2.0 to 2.23. If we take the DBT and we do not perform the FFDM, that means we use the DBT to construct a 2D to give a synthetic 2D image, then the dose would be similar to a 2 view DBT. So note that all these views are still, even with the combo, meaning to say, even if we do a 2 view DBT and a 2 view FFDM, the dose is still less than 3 milligray. Some other factors are patient factors which affect dose are breast thickness and breast density. Breast thickness, because the thicker the breast, the longer the path the X-ray has to travel through, and I think Dr. Brady has explained that quite nicely. Breast density, the radiation beam needs to have a higher amount of radiation in order to penetrate the density and a dense breast, and therefore, in order to give a good quality image, and therefore increases dose. And the best way to address these issues would be breast compression with a compression force of 100 to 200 newtons. This allows the breast to be compressed between 2 to 9 centimeters. When the breast is flatter and more even, there is less scatter, less image degradation, and this leads to better image quality as well as reduction in dose to the patient. So how do we optimize mammography? There are environmental factors and also the important role that technologists and radiologists play. So this is an image, a photo that I just took of one of my mammography rooms in my department. You can see that the wallpaper decoration on the wallpaper has got pink flowers and pink butterflies, and we hope to create a warm and welcoming environment for the patient so that she is more at ease. So being Breast Cancer Awareness Month, we have decorated our breast center. So this is an arch of balloons that is at the entrance of our breast center, and I always it never fails to bring a smile to my face when I see this. And I also see patients taking photos under this arch of balloons, and that is really nice, because I think that gives patients a good experience when they come for their breast imaging. Technologists play a very important role in the patient's journey. So an empathic and patient-centered approach is very helpful to reduce patient anxiety. And when the patient is more relaxed and more calm, she's able to cooperate with you much better. And then the technologist is able to perform optimal positioning as well as compression, and this leads to a good quality image and reduces the need for any repeat views, and therefore maintaining those to a minimum. Now let's take a look at some clinical examples. This is a 68-year-old lady who came for screening. And she was recalled for an asymmetry that was seen in the right upper outer quadrant, as denoted by the pink arrow. So we recalled her, and one of the ways to work out an asymmetry is to perform DBT, tomosynthesis, which was done for this patient in the CC projection here. So I'm running the CC DBT images here, and we can see that there is no focal mass in the outer breast here. It was done in the CC as well as the MLO. So this is the MLO projection, showing no focal underlying mass in the upper breast. A supplementary ultrasound was also performed, and this did not show any focal mass in the area of concern in the right upper outer quadrant. So here I have two images. This is the first image that I showed, the right MLO view, for which she was recalled, showing the focal asymmetry. Here, I've just blown up the numbers here. The force was 100. Breast thickness with a force of 100 was 45 centimeters. She subsequently returned for follow-up imaging 1 year later, which is this image on the right. And we can see that the force is 118, so more force this time with breast thickness of 34 centimeters, so decreased breast thickness. And we can see that the asymmetry that was initially seen is no longer present. So I showed this case to demonstrate the importance of adequate and optimal compression. And this can help to reduce false positives and reduce the recall rate, reduce patient anxiety. So a good mammographic technique is very important. The proper positioning with optimal compression. This helps to reduce blurring artifact, results in a high quality image, and therefore will set the stage for accurate interpretation with fewer recalls and better outcomes. How about the radiologist's role? Generally, for screening, there is the interval, the type of screening has already been decided. When the patient undergoes is needed to undergo additional mammographic views, this is when the radiologist will prescribe the different types of additional mammographic examinations. For example, architectural distortion is usually worked up with DBT. Mass or asymmetry is usually worked up with spot compression or DBT. Calcifications are worked up with magnification views. And some patients have multiple findings, and the workup will then depend on the type of multiple findings. This is an example. She's 43 years old. She underwent a screening mammogram in 2023. She is recalled for an asymmetry in the right upper outer quadrant. So we called her back for DBT in both the CC and MLO views. So this is the CC tomosynthesis cine clip. There's a prominence of parenchymal tissues, but no focal underlying mass. This is the MLO view, showing fairly dense parenchymal tissues, but no overt underlying mass. Because of the breast density, we also took her back for ultrasound. So these are side-by-side mirror images comparing the right side and the left side. on ultrasound, there is a focal prominence of glandular tissues at the 10 o'clock position when you compare the right upper outer quadrant at the 10 o'clock position to the left side. In the transverse plane, same finding focal prominence. And therefore, the DBT has been used to answer the clinical question of asymmetry in the right upper outer quadrant, which is due to focal prominent glandular tissues. So the subsequent mammography, we have already worked her up, and then we can just compare with the baseline imaging as well as the workup. In this next example, she's 62. This is her screening mammogram. And there is a small asymmetry in the posterior central left breast, as denoted by the pink arrow. It's very tiny. It's only seen on the CC view. It cannot be seen on the MLO view. So we called her back. For this patient, we did not opt for DBT. We opted for spot compression views. This is because the posterior central part of the breast here is a difficult position to image and access, and may not be reached by a DBT examination. So this is the spot compression view with direct CC compression. So just superior inferior compression. We can see that the asymmetry is still present. So because of that, we did a rolled spot compression view. So you can see that it has gone away. So this is probably an area of, again, focal asymmetric and slightly prominent glandular tissue. And this technique with spot compression view shows that it is still useful, because there are some studies that have shown that possibly DBT can be used to replace spot compression views. But spot compression views can sometimes be useful when the area of breast is very posterior, like in this case, or if a different plane of imaging, for example, if you want to change from MLO to LM or a rolled view, a spot compression in a different plane can be performed. This next patient, she's 47. She presents with a right breast lump, and we can see a mass here in the right upper outer quadrant, as well as an enlarged axillary node here in the right axilla. And as you can see from this these set of mammography images, her breasts are very generous. And she underwent 2 additional CC views that were performed for each side. So the set of images on the left are the CC views with the nipple in profile. And this is the set of images on the right are the extended CC views, showing the axillary mass and showing this mass better. Here you can see the nipples that are being projected over the breast. So for this patient, we also found additional clusters of calcifications in the right breast, which needed to be worked up. So she underwent magnification views for further evaluation of these calcifications. And because of the breast size, the big breast size, it was difficult to perform the magnification view. So a total of 4 LM and 3 CC magnification views were performed to evaluate these several clusters of calcifications, as you can see, which are circled here. So one suggestion I have when faced with these patients with generous sized breasts and with multiple findings that need to be evaluated on magnification views is to use magnification of lower magnification, maybe 1.5 instead of 1.8. Because with a 1.5 magnification, we would be able to include more of the breast, and this would be able to capture the calcifications or the areas within the breast without doing so many views. This other patient, she's 69 years old. She presents with a right breast lump, and on the 2D views, we can see some skin thickening over here. This is the BB marker that has been placed over the right breast lump. We can appreciate some stromal distortion in the upper outer quadrant. So to evaluate this, the appropriate additional magnification view would be a DBT. We also see a mass here, but it's partially obscured. by the dense tissues, and she has extremely dense breast tissues. So here are the DBT images. So on the right breast, we performed the MLO NCC DBT, and we can see nicely demonstrated the stromal distortion in the outer breasts here. And on the MLO view, again, the distortion here. And here we can see it extending towards the skin with skin thickening. There was another area of distortion, and this was all in the upper breast, in the upper and the outer and central region. This is the left breast here. This is the tomo in the MLO plane. And here we see the mass with spiculated margin in the left breast. So for this patient, she underwent only one set of tomo images for the left breast. These are ultrasound images. The right breast, there is a large irregular mass occupying most of the right upper breast. There is extension to the skin in keeping with skin involvement. Mastectomy showed an 85 millimeter grade 2 invasive lobular cancer with extension to the skin. And she also underwent left mastectomy, which showed a 5 millimeter grade 2 IDC, a very small cancer, which corresponded to the nodule, the mass that was seen on mammogram. So I put in this case to show that DBT is useful. And often we can perform DBT in both the MLO and CC planes. Sometimes we can perform the DBT in one plane to evaluate an abnormality, especially in cases where the mass is only seen in one view. For example, if it's only seen on the MLO view, then it would make sense to just perform the DBT in the MLO plane. Or if we are very certain that the findings or the evaluation is sufficient with just one MLO, one view, one plane DBT. So this would help to reduce the radiation dose to the patient. This is a 55-year-old who underwent screening mammogram. Here we see stromal distortion in the upper outer breast. These are two BB markers which denote an area of surgical scars from a number of years ago. So that's the distortion. She was recalled for, and she underwent further workup with tomosynthesis. This is in the CC plane. And this is in the MLO plane. And we can see distortion here. I think it's better appreciated on the MLO plane. So here, so the MLO plane demonstrates this better and confirms the presence of distortion. We also noted calcifications in the rest of the breast. So she underwent magnification views as well. So there are calcifications associated with the distortion in the upper outer quadrant, as denoted by the pink circle. There were additional groups of calcifications in the central and slightly medial breast here, as denoted by the orange arrows. These calcifications are sort of superimposed upon each other on the LM view. So they span a distance of around 4 centimeters. So the magnification view provides additional information on the extent of microcalcifications. These are her ultrasound images showing irregular masses at the 1 and 12 o'clock positions. Biopsy of these lesions showed DCIS for both nodules. These are her MR images, and MR shows a large area of non-mass enhancement extending over the upper central and upper outer breasts. She underwent a mastectomy, which revealed 45 millimeter intermediate to high-grade DCIS. So to summarize, optimizing mammography can be affected by various factors. When the environment is patient-centered and comfortable, patients have a better experience. Patients will feel more comfortable and more at ease. Technologists who are professional and employ an empathetic approach I think, very, very helpful to allay patients' anxiety. And I think one thing I like to say is that for technologists, to a patient to you might, be just one patient in a very busy day. But I think to the patient, an empathetic and friendly and warm technologist sometimes really makes a world of difference. And of course, with a competent and skilled technique, this will result in an optimal mammogram image. The radiologist's role is to prescribe additional mammographic views, and this depends on the type and the location of the lesion in question, and if there are multiple lesions. And it is up to the radiologist to employ appropriate and judicial use of these mammographic views in order to answer the clinical question with the least amount of radiation possible. So it is important for all of us to play our part in the patient's breast imaging journey. And with that, thank you very much. And yeah, I'll be happy to take any questions.
Thank you so much for for your talk, and you show a lot of patients with the really interesting mammogram images, picture, and the solution. So I think we have about 8 minutes for the question and answer session. And in the meantime, for the audience on the VDoctor platform, if you have any questions, please feel free to type your questions to the chat box. And we all know this is awareness month, and we know that screening is important, right? So this is a question for you, Sam, that about how to purchase the machine. So since we know that the digital breast tomosynthesis is on the market, and which means what is your recommendation for the best image quality if we want to purchase that thing in terms of the narrow angle or wide angle on that machine to get the best image quality and maybe worth the money that we spending, get the good screening result?
Sure. I think Dr. Tao mentioned this, showed this very well in her images. Being able to go through and leaf through the images and having good resolution from slice to slice is probably one of the more important aspects. And so a wide angle acquisition is really good. Now, if your system can do a wide angle, it can do a narrow angle. If you buy a system that can only do narrow, then you can't do wide. So I would always default to make sure you get a system that can do wide angle, because it can do both. And then obviously it can show all the information you need in the image.
So how much difference on the price? I'm not sure. Is it the wider angle is more expensive, super expensive or not? Probably not, right? No. Okay.
They standard. They all come standard with the ability to do about 30 degrees.
I see. Yes. Thank you. So I think Dr. Jamari has a really interesting questions too. We cannot hear you. Can you unmute? Or you want me to read your
Sorry,
question?
just a short question to one for Sam and one for Dr. Win. Okay, right now we use CT for many things, right? And to my understanding, it's also have especially for CT chest, it also have a radiation dose to breast as well. But then if a patient has underlying kind of disease that always follow up with CT, what should we recommend for the patients about the screening mammogram? It should be every year, or how about the technique that the technician should be aware of when he or she perform the mammogram? Kind of how you recommend the technician on combination of radiation dose from CT and also the radiation dose from digital mammogram?
Yeah, I'll start and then I'll definitely pass this on. I would say incidental findings in CT happen all the time, but the CT acquisition was for a specific purpose. And if you have an incidental finding, say in the breast, those patients are almost always going to be referred for breast imaging, dedicated breast imaging. Obviously, you can use ultrasound or other modalities, but in the end, when you do X-ray based mammography for screening, that's important to be able to review the intervals of the change and to be able to see this and to be able to have prior images. And that's important. So having CC-MLO views, your DBT views, those are important. The CT itself, traditional CT, does not necessarily replace that. But I'd love to hear from the radiologist.
Yeah, I mean, if the patient has certain lung disease that need to follow up with CT, right? So definitely every time the patient receive the CT study radiation to breast, but then the patient also needs annually breast screening mammogram. Any comment, Dr. Yuen?
Dr. Chamri, I think that is a very difficult question to answer. Yeah, extremely difficult. So there are patients with lung issues, maybe cystic fibrosis or maybe bronchiectasis or even, just high risk undergoing lung screening, for which we would recommend a low dose screening CT. So that helps to reduce the dose. If she's a female, then that is even more difficult because then we have to balance the benefits versus the risks, and that's what life is at the end of the day, right? So I think I would look what I would do if I were to make a recommendation to my breast surgeons who ask me this question. I would say, let's look at the risk of the patient. Is she high risk? Is she of normal risk? We can use any of the risk breast cancer risk calculators, and then decide if she is of normal risk. Then we may consider, whether she is she should start at 40 or even 50, depending on which country or region you are in. Some people start at 50, some places start at 40. In Asia, the breast cancer incidence, personally, I believe that in Asia, I would start at 40 because the peak incidence actually is in the mid 40s as compared to in the US. And so I would start, but then therein so I did talk about the lifetime attributable that LAR, the lifetime attributable risk. I'm sorry, it therefore is a higher risk if she starts earlier. So again, it's a balance. If she has very difficult to really to have a definitely right or wrong answer. I think there is none. I may screen her maybe with closer intervals between 40 to 50, and then at maybe a biannual interval when she's older in order to reduce the radiation dose. I may add on ultrasound if she has dense breasts. So there have been some papers which looked at using just mammogram, AI, and ultrasound, and they have found a very good cancer detection rate, similar or better than tomosynthesis. So I may, instead of using tomosynthesis, then use these other tools. Like I think AI, Dr. Brady made a very good point. I think AI is something very exciting that we can certainly use to increase our cancer detection rate. And so I think we need to use all the tools that we have in our toolbox to really offer the patients the best benefit is to risk ratio. And that's what we're really looking at, balancing the risk and detecting breast cancer early is something very close to my heart, because I think breast cancer is a risk factor for all women. We have this very powerful tool, but it has thorns, it has pricks. So we need to be careful. We need to, sort of like find ways to avoid those thorns or to trim those thorns as much as possible.
Thank you. I think both of you have give a very, very good point in terms of look at the patient as a patient, not a brace, not the brain, not the chest, right? So we divided our series into modalities, but every modality is linked. We not consider those only the breast, but we need to consider when we talk about CT scan and how we're going to link with other modalities. That's the very great point from our lecturer. Thank you. And even one last question, because I getting older, and I remember that we recommend screening mammogram until kind of 75.
Yes.
And now people live longer and longer.
Yes.
Do we
Yes.
change our recommendation?
It's a fantastic question. The oldest patient I have I experienced, I encountered in my center, she was 91.
Oh, wow.
She was 91. I mean,
should she stop or
she
should she
was-
continue if she live
she was sent to
120?
us, then we just carried on, you know. So yeah, I think many screening programs recommend up to the age of 75. There isn't very much data for screening beyond the age of 75. I would say that I think there have been some recommendation, I think from the American College, that we can stop screening up to maybe 4 to 5 years before the expected lifespan. So if she's a good 91 and she is like, you know, hiking and she is, you know, having, you know, she can lift weights. I read some report, you know, recently that there was this 85-year-old lady who was lifting weights and she was so strong. So I think she's a good 91 by all means.
So continue doing it. Okay.
Yeah. Because I think if we detect an early cancer when she's 91 and, you know, we can detect it, then we can certainly treat her.
Good point.
Okay, thank
Good
you.
point.
So,
Right.
Dr. Superkun.
Yes, thank you so much. So I would love to continue the conversation and discussion on this thing, but somehow like our time is up. So thank you so much, both of you, for giving very informative talk and insight and reiterate on how important that we need to see the patient as a patient, like a patient-centric. Not just like a modality, subject in the paper or something. This is patient and this is a real human. So thank you so much. And for the audience, as I mentioned earlier, that we need your input on how we do things and what do you want from us? How can we improve these lectures? Do you want to have this lecture for 2 hours to have like a more conversations or something? So please give us the evaluation, scan this QR code or click on the link on the VDoctor platform. And also, as a reminder for the next session, which is a wrap up, the finale on the enhancing optimization strategy, that we're gonna have a team. It's a team effort to make this thing better. That we're gonna have like this is as I mentioned, this is a team effort. So which means including radiologists, technologists, and medical physicists to make things better. And how can we move forward for the optimization strategy? So we're gonna have Dr. Bradley come back again as a finale and set a benchmark for us, like what he's doing in the US, like what is like the practice that they are done over there. And then we're going to have the people from the Asian Oceania country as a representative for the technologists, medical physicists, and radiologists to form the forum and has more like a discussion on how we can do this thing better, how can we set this thing up, and to make the better healthcare system or like the practice in our region. So thank you so much all for joining us today, and I hope to see you all again next webinar series. So thank you.
Thank
Yep.
you. Thank you.
Thank you. Have a good day.
Ma'am, with your permission, may I close the session, ma'am?
Yes, please. Thank you.